what we're doing for sickle cell and thalassemia is very, very important. We work in a team at St. George's. St. George's is part of the Hemoglobinopathy Commissioning Center, Northwest Hemoglobinopathy Commissioning Center. There is also the adult hemoglobinopathy pathway. We have the pediatric pathway, but antenatal was mostly in the community. However, when that appointment was given, we then established case loading or providing specialist antenatal care for pregnant women who have hemoglobinopathy conditions. So including thalassemia, alpha thalassemia. When I say alpha thalassemia, because some of them may be carriers and they have to be monitored as well. We provide genetic counseling, which is done by myself as the lead. I don't want to go into case loading for the women with the hemoglobinopathy conditions that are pregnant, but because of the purpose of the conference, I go straight into the genetic aspect, the genetic counseling services that we provide. We also provide education and training for staff and pre-registration midwives, which actually has been raised up by the all-party parliamentary group as an awareness into lack of training for midwives and nurses. And I wasn't aware of this until recently, and I said to myself, this is what I have been seeing, or we have been seeing. So in view of that, we provide education as well in order to improve the service and to address the inequality in services for sickle cell and thalassemia. So this is where St. George's stands. So why is it is important for midwives and nurses to be much more aware? It is everybody's role. It is everybody's role to look after sickle cell and thalassemia, because from conception, for midwife, it starts with us. It starts with us because we do genetic screening or we do counseling. So midwife has to be abreast. Now, the evidence shows that between April 2007 and March 2017, there were 3,206 babies born with sickle cell disease in UK. Or England alone. 260 to 350 babies born each year with sickle cell condition. Now, we talk about sickle cell, we're talking about hemoglobinopathies. We're talking about beta thalassemia. Between 20 to 30 patients are born with beta thalassemia major. And alpha thalassemia is the one that I'm fear of, because that is the one that is not compatible to life. And that's the one that seems to be not much understanding at all. At least for sickle cell, you will see that the genotype is written, so you can refer. But alpha thalassemia needs a bit more investigation. So I actually agree with Amanda, also the guideline and the standard of early screening, because the alpha thalassemia takes longer to screen, because they may need DNA testing that will take a bit longer before they go for PND if they decide to do. Because the alpha thalassemia major is not compatible to life. That attention is needed, and it actually has mortality consequences for the mother who is pregnant with alpha thalassemia baby or a baby with fetal hydrops and not diagnosed. So the guideline, I think we have been much aware that by 10 weeks gestation, we should do antenatal booking at least to be able to identify those women and couples at risk. Offering genetic counseling, just slipped through that. And also by 12 plus weeks gestation should be offered the PND. What is the purpose of the antenatal screening? The purpose is to support women to make informed choices early in the pregnancy, promote clear understanding and awareness of the genetic conditions, and value for screening, preventing infant mortality, as we mentioned already, and identify affected babies. This is very, very important as well. Identify affected babies and facilitating timely transition into clinical care. Antenatal screening. So how do we go about that? All pregnant women who have unusual hemoglobin are offered genetic counseling and screening of the biological father of the unborn baby. This is where or most of the time, the challenge is how to get the men to come in to have the screening. Sometimes it may need that. If it is a midwife, you're going to give more information. Sometimes they ask for the counseling. But I've left my book on the table. One of them that is a guideline for screening, which is given to women in early pregnancy. That helps a lot. So when I speak to them or we speak to them and they want more information, they are directed to that book to read about it before they come for counseling. Sometimes we may have to do video. The man may come in his own time, but the woman may not be available. So we've just got to find a way around it in order to get them screened, because without that, the risk is, we can't process through with the screening. Now, there is also, I've put here, screening for the IV, genetic counseling for the IVF pregnancies. I think it's done something that it causes midwives and other professionals very challenging. Why is an IV pregnancy? Why should we do, because we say it's something that is being prepared or they've had counseling and treatment already. But remember, even some IV pregnancies are coming from outside the UK. And how much do we know the screening effectiveness of those screening? So these women need information about the pregnancy. We have to give verbal verbal and written information to educate them and to make informed decisions and informed choices. Now, the 1 in 4 chance is always explained for them. It's also important for us, we give information verbally and also written information to prepare them for the newborn screening. Because it's not just doing the antenatal screening without mentioning the newborn screening. So it's very important because it's a twin screening. UK, we do twin screening. Some countries, they do preconception, premarital counseling. So there's different kind of screening. But UK, what makes it better is that we have the antenatal and the newborn screening, which is important for us, for our patients. Sometimes there's so much stories, and I didn't know which one of them should we pick up to tell about. Now, this lady is AS carrier. Both parents are AS carriers. Now, we know that because of the genotype, SS is the results. So she had the counseling at 9 weeks gestation, 12 weeks plus, she had the PND. Results came and baby is affected. And one thing we have to realize that screening is one thing, identifying them for them to accept that they are carriers is another challenging. But they need that support. So after this, she decided to continue after the PND, the results was given. And we promised her that there is a support. There is pediatric team to carry her through if that is her wish. But then she called back in 2 days' time to say that she doesn't want to continue the pregnancy anymore. She had then had discussion with the family, with her partner, and they have made a decision to discontinue. In fact, with her religious beliefs, that is one thing I always say, when you're doing the screening, do not assume what somebody will tell you. It's not right. Sometimes it challenges my mind, some of the things we see and we hear. Because she wanted to continue because of her religious belief, but the family advised her that she can end pregnancy based on the condition. So she came back and was referred to fetal medicine midwives to facilitate her choice of the process. And information was given. We didn't just leave her there like that. We took her through in terms of referring her to the geneticist. Because, the geneticist, I don't know, in some places, the geneticist will give the counseling. But in George's, we do the counseling. I'll do the counseling, and my other colleagues will do the counseling as well. But we refer her to geneticists to follow up, to refer to to triage, to refer to for pre-implantation, PGD, so that she can plan for her next pregnancy, if I can come back on that. And also referring to psychologists, so she can have psychological support after the end of her decision. This is used very much so in counseling. It's very, very important for women to understand the inheritance pattern. Because many men say, I'm not a carrier, and there's none in my family. But when you give them information, they go back and showing them the various genotypes. They come back to say, oh yes, my father said so. And I have to mention here, the last one, that is the HPPF, hereditary persistent fetal hemoglobin. That one is, I found 3 from England, pure English, they have that. About 2 from Scotland who have that. And that is the high fetal hemoglobin. It becomes like a genetic, and that can pass on in the family. So hemoglobinopathies is a condition that is complex, but we need the time to study and understand to support our patients. The story of patient 2 is she was a carrier, both of them are carriers. She said, though, we have to listen to her, that she had a neonatal death resulting from sickle cell disease at 3 months of age. In her second pregnancy, we look after her, and the baby was affected by HBSS again. That in the third pregnancy, she was very confused, but we needed to carry her through. So she decided to have a PND, but when the day came, she stopped because she couldn't take it. Because of her religion, she said, she cannot end the pregnancy. You see, these decisions are based on culture, beliefs, faith, background. So we need to really understand where they are coming from in order to provide them the care that they deserve. So she decided to continue with the pregnancy, and capillary testing was discussed, and newborn screening was offered, and we went through with her. And finally, she was referred to the pediatrics team so that they can continue looking after the baby. Just an example of capillary testing is just the taking of the blood into the bottle and then sent to the lab. It's not like the newborn screening. The newborn screening is the final results. It's just trying to find initially how it's going to be. Because obviously the fetal hemoglobin will be much more at that time of the capillary testing, but the newborn screening will confirm the correct genotype. So it says here that some of the principles that governs our screening or our service is that we ensure interdepartmental and organizational working together to facilitate screening pathways and standards. Ensure data is produced, validated, and reported according to the National Screening Committee and Commissioner expectation. And we ensure that the appropriate trust policies in place to reduce risk or to manage risk. Ensure early reporting of incidences to the NHS England and the quality assurance. And that is me. Thank you for the opportunity.